And then, alrighty, so I'm going to introduce you, and then after that, you can share your slides and start your presentation. So
Okay.
welcome everyone to the Pakistan International Neuroscience Society Meet the Faculty Lecture Series. I will be your moderator for today's session. So before we get started, some housekeeping rules. Please type your questions in the chat box. When the presentation ends, you could either unmute yourself and read the questions from the chat, or simply raise your hand and if you want to make any comment. Please keep your microphones muted during the lecture to minimize the background noise. So without any further ado, it is my absolute pleasure to introduce Dr. Ali Rajput, a distinguished professor at the University of Saskatchewan, Canada. Dr. Rajput obtained his medical degree with highest honors from Liaquat Medical College, Pakistan in 1958. And then he moved to the United States for his neurology residency and master's degree at the University of Michigan. It was followed by 1 year of neuropathology training at Queen's University, Kingston, Ontario. Subsequently, he joined the University of Saskatchewan medical faculty in 1967, established a movement disorders program, and founded the Movement Disorders Group in Canada. Dr. Rajput has many national and international awards to his name. Personally, the most impressive one is when his work was chosen as one of the 4 most significant advances in medicine in the 100-year history in the province of Saskatchewan. Talking about his excellence in research, he has published extensively and served on editorial boards of several high-impact journals. He has made over 4,000 patient videos and conducted over 600 autopsy studies of his own movement disorder patients, and more than 500 of those brains are currently in his freezer. He calls this the brain safety deposit, not a brain bank, because he does not perform autopsies on patients not seen in his clinic. His Parkinson clinic is recognized as one of the best in Canada. His long-term clinical data with pathological verification of diagnosis and frozen brain material is widely recognized as the best resource of this kind for research. Well, I can go on and on about his outstanding career, but as myself a movement disorder fellow, I want to point out that how privileged we are to have a role model in movement disorders with us this afternoon. Thank you so much, Dr. Rajput, for accepting the invitation, and the floor is yours, and you can go ahead and share your screen.
Well, you're welcome.
Just a minute. Where do we share?
So can you see a button at the bottom? It's like a green color. It says share screen.
I thought we did that. Just a sec here. It's not doing. Oh, there. What's happening?
So did you click on it?
Share screen. There's all whited out here on the bottom.
So
I've got I got full screen.
So you got the full screen.
Ali.
So if I press escape.
So yeah, press escape and.
That's it. Okay.
I can't get on.
I don't see anything here.
So do you want me to share the presentation and
yes.
I can?
Yes. And you'll have to tell Dr. Rajput when to.
Yeah.
Okay.
Let me go to my email address and then.
How come we couldn't get it to work this time? So on our screen is this meeting is being recorded. How do I get rid of that?
So yeah, so we record our lectures so that if somebody cannot attend it because of, for any reason.
Yeah. But it's right up in the middle of his screen where he's trying to do his presentation.
So let's see if I share my screen, does this go away? How about now?
Nope.
Nope, still.
We can see your screen now though.
Okay. How about now?
No, it's still right in the middle of the screen.
Okay. So can you, if you click on it, are you able to kind of, move it around and kind of put it on the side?
Oh yeah, there I can do it. Yeah. Oh.
Okay.
Okay, but.
So you guys, you can go ahead and start the presentation and just let me know and I will move the slides for you.
Okay, so you still have. I do that. Now I can't get my pointer back. Can you put the pointer, oh, then we're not gonna be able
That's
to
fine.
point it. Okay.
Are we ready?
Yes, we are.
Okay. Assalamu alaikum.
Walaikum salam, Ali. How are you?
Good. How are you doing, Shoaib? Ashfaq?
Tipu.
Tipu. How are you, Tipu?
I'm good. Alhamdulillah.
That's good. Well, glad that you can join.
Yeah, of course. I didn't know. I just found out, so I joined.
And you.
Ali Ashfaq, I'm also listening in. I'm in a car right now.
Oh,
So you can't see me. I'm looking forward to your presentation.
Okay. Well, good to talk to you both. Well, I'll gear it towards the younger generation of people, but anyway, so good to talk to you both. Now, I'm going to give you a bit of background where I am from Pakistan. This map shows a little village called Chak number 30 if you're Punjabi. If you're Sindhi, you call it Day number 30. And Sindhi also say Goat number 30. So this is a village here. And it is about 8 miles away from Sangar. I was born there, and then I went to high school in Nawabshah, that's number 2. And then I went to college, and medical college in Hyderabad. And then I did a practice of neurology for about 1 year in Sangar. And after that, I came to the US. Still, I'm unable to see this part of it, this, can you get rid of that part?
No,
The top left part?
yeah, we can't. Oh, there.
Okay, that's right. Okay, you got it.
There, okay.
Okay, for the younger people, as I understand, most of you are neurologists, neurology in training. Some of you will focus on clinical practice with some undergraduate and postgraduate teaching, but others would pursue research. I want
Here, I brought it for you. Thank you.
Can you hear me?
Yes, we can hear you now.
I want you to know that there is a lot of room at the top. If you're doing something well, you will be successful. So don't hit for the bottom, go for the top. If you can reach the top, you'll have a lot of options. Whatever you do, if you do it well, you will be successful, as I said. Every place has its own strengths and weaknesses. Consider those before you make long-term commitments. This for your training and for your future, these machines.
Yeah.
Okay. There are different specialized equipments available at different places. There are different financial support systems available at different places. There may be a strong program which you want to join where you are being trained, or another place that if you join a program that's already going on, that will shorten your first phase of research. Starting a new program takes time and patience, but it has its own advantages. Healthcare systems are different in different countries, and even within the same country, there are different institutions. So you have to keep that in mind. No, I have to go back.
No, he'll change it.
There are several different models of research. Now, all of you are being trained as neurologists, so I don't have to teach you, say anything about clinical neurology because you are spending 4 years in training at good places, so you're already good neurologists. You have to assess the local circumstances, your personal interests, and the situation, and then pursue the research. You must like what you're doing. If you force yourself to do something which you do not like, you cannot possibly be happy and successful. So choose the place that you like, the work that you want to do. The major components of research, the end product of all medical research is measured by the publication in refereed journals. That's the main measure, although some places will look at it, how much money did you bring, and research grants did you bring in. Every publication has the following major headings. If you read the journals, you'll see objectives, the topic that you want to study, and why do you want to study that, the material that you use, the methods that you use, results, and the conclusions. So those are the main headings under which you have the publications. And so you have to work accordingly to find the topics. So you have to find the topic which you want to study first thing. Where do you get the ideas for research? These include from your patients asking you questions, observations that you make in the patients, what you have been taught by your professor, is that accurate or is that not? And you have the right to question that. What does the current literature publications indicate? What is the currently unresolved issue that you can handle? What is being debated during the meetings? And you go to the meetings and you will hear those controversies. And then you will see, what am I seeing? It does not seem to be matched with what the other people are saying or what the literature says. So you have the right to question that. And I will go over some of those with you. How I approach those issues. Research is pursued by clinicians and basic scientists both. The basic scientists have an advantage. Excuse me. They are experts at methodology, and somebody like Tipu Siddiq is both combination of basic and clinical, so is Ashfaq. They are experts in methodology, and they typically focus on one or two methods, and they're experts at that. By contrast, clinicians have an advantage of having more clear objectives. You see the patients and you have patient-related questions that you ask yourself or the others. You're having the best material to do the clinical research. You have the patients to do the research, but you need appropriate methods. So you either develop those methods or you invite others to join you. All biomedical research is aimed at application to human beings, and therefore it must pass through the final phase of assessment in the human subjects. No matter how many animal studies have you done, lab studies you've done, eventually it has to pass through the human subject before you can apply to the human beings. Every day you ask yourself questions, you ask questions, what does this patient have? How did this happen? How can it be treated better? So you have a lot of topics at your disposal. In the first category, what is it, the questions that you have, the objectives that you have. My training in the USA was from 1960 to 66. I did 1 year of rotating internship. That was at that time the norm. We did the rotating internship. Then I did a year of medicine residency, psychiatry residency 1 year, and 3 years of neurology residency and masters of neurology in University of Michigan. The decision to pursue neurology was really, I didn't know what I was going to do. So I ran into this Pakistani doctor, Khalid Hamid, who was very nice to me. He was senior to me in Chicago. So we sat down and said, well, which area should I specialize in? So after a discussion with him, I said, well, I'll be a neurologist. There are not many neurologists in Pakistan, so I'll be a neurologist. So that's what made me a neurologist. The Canadian, why I moved to Canada, the Canadian Royal College certification was recognized in Pakistan, but the US certification was not recognized. So I moved to Canada in 1966. I did 1 year of neuropathology residency in Canada. After I passed my Canadian Royal College examination in 1966, I could not find a position in Pakistan. So I accepted a position in Saskatchewan in 1967. Excuse me, and I have been here since then. Now this is where Saskatchewan is, those of you who do not know. This is map of Canada, and this is map of the US. You see, we up from North Dakota, and this province of Saskatchewan, Saskatoon is located right in the middle of the province. So it's a large province, about the area of Texas, and in really European terms, it's twice the size of Italy. So it's a very large area, but only 1 million population. When I came to Saskatoon, the status of neurology was such that research was not a requirement of my job, although I had a full-time job. That research was my own choice. There was a good clinical neurology program, but there was no interest in research except one colleague had some research for a couple of years, then he left. There was no culture of research. It's a small, clinically focused medical college. No money for research, no manpower support, no specialized machinery, no mentors. But I had the university tenured position. There was small but guaranteed salary. I didn't have to worry about earning too much money. So I could spend as much time on patients as I wanted to and see them as often as I wanted to. Saskatchewan, you should know, is the province where the Canadian medical care system started in 1962. So we had a leg up on most of the other Canadian systems, Canadian provinces in that regard. Now, where did I fit in the 1960s? Well, Parkinson's research in 1960s was focused on observations of levodopa treated cases or brain biochemistry. In science, there's no allowance made for your lack of resources when you're trying to publish a paper. I realized that I could not compete with the larger centers for the number of patients that I had. Their paper with 10 times as many cases would have more credibility than my paper would have. I did not have the training nor the material to do the brain biochemistry. So I was really out of the loop for the research of that time. In order to compete for research, I had to find a new approach to it. The first decision I made was, whatever I do, I must do it as well as anybody can do anywhere. So I limited my focus on the excellence. And that's what I've said. If you are doing things well, you will eventually succeed. Before I started my long-term program, I did some clinical studies based on what I had learned during my training, what was being reported by others, what I was observing in my patients, and I will share some of that with you. Now, this is a paper published in 1984. I'll give you a background of that. In 1961, Burkmeyer and Harnikevich reported a study of intravenous levodopa use. That's the first levodopa use in human subjects. And they found that they used a very small dose. It was only intravenously. And they found that the higher dose had more benefit. And then in 1967, Kotzias reported that a large dose of DL-dopa was also effective. Now, to give you some idea, they used up to 16 grams, 16 grams of DL-dopa in some patients. They also found that the patients developed dyskinesia, which you see in the movement disorders, and that those dyskinesias were often present or usually present in people who benefited from the medication. So some people put it 2 and 2 together and they said, well, dyskinesia is an indicator of benefit to the patients. There was no dose finding study ever done in levodopa. So a large number of neurologists, the first batch of neurologists that got to use that, they were using large doses of levodopa. It wasn't uncommon to use up to 9 grams of levodopa. I'm talking about plain levodopa, which is 1/5 as potent as cinnamon is. So there were people who were using a large dose of levodopa. I was not in the first group of neurologists to use levodopa, but in the second group. So some of the patients that had been treated from this province elsewhere, when I started seeing them in my clinic, they were directed to me. So now I had the benefit of seeing patients which others had seen and treated. And I saw dyskinesia was so common and sometimes so severe that they were falling off the chair. So I said, my goodness, what am I doing with these patients? And my patients, I should tell you that when I told one patient that some patients have received up to 16 grams, that is 32 pills. So he looked at me, these are farmers, they're straightforward people. I said, Doc, you think I'll be eating too? Or would I be taking only these medications? So I realized this was really not making any sense to me. So I, on my own, decided that I will be using a lower dose of levodopa. Now remember, I was just starting, and therefore I was going against all the experts of that time who were using large doses of levodopa. I knew some people who were using levodopa until the patients developed dyskinesia and then backed off. Mine was just opposite. I wanted to see that they have benefit from the medication, but they did not develop dyskinesia. So I found that the dose approximately 1/3, that is instead of— Recording in progress. Pardon me? Can you see me? Can you hear me?
Yes, we can hear you. There was just a background noise.
Oh, okay. So I decided on 1/3 of the dose, that is 3 grams of levodopa, which will be 600 milligrams of cinnamate. So I've used that since 1968, and I published that in 1984. Now there's a study that Olano and co-workers published in 2013 in Movement Disorders. They found exactly the same dose to be the most effective dose. So that's how I dare to differ from the senior people and said, no, I'm not going to use that dose. And I stuck to 1/3 of the dose. In longer term, my patients did better. They had fewer side effects. And one of the other things that some of you might have heard, that after 5 years, the group comes back to the baseline. That is based on my study. I'm not going to be able to show you that, but that's what it is. So that's how I, on my own, decided, but I wasn't going to tell anybody until I published, because I was going against the grain with the experts. So I published that in 1984. Well, this paper is based on what I was taught when I was a resident. My professors taught me that when you have any doubt about the tremor, if you give them alcohol, if they improve, that means they have essential tremor. So there was no scientific evidence. It was a hearsay thing. So I decided I'll test that. So this was a very nice clinical study. We evaluated the patients before alcohol, then gave them alcohol, 1 ounce of alcohol. Then 1 hour later, we drew the blood alcohol levels and did the same test. Well, a large number of patients with essential tremor improved, but also a large number of Parkinson's disease patients' tremor improved. And even a cerebellar ataxia patient improved. So we wrote that it's not a test that you can use to make a diagnosis of essential tremor from other tremor. So that was a very simple sort of study, but you can think of those studies. My progression of research was slow. While I was still in my clinical phase, and I did some other studies, I'm not going to go over those, I decided to do the detailed clinical examination using the scales that were usable, that were available at that time. There was Hohmann and Yahr scale and Webster scale, which most of you are not familiar with. I was making videos on all consenting patients. The next phase was the neuropathology studies. Excuse me. Now, neuropathology was done a long time ago, when it was established in early 1900s. The nature of Parkinson's disease, the Lewy body Parkinson's disease, and substantial Niagara damage, that was established already. Then in early 1960s, there were studies came from Boston, came on striatonigral degeneration, study from Toronto came on progressive supranuclear palsy. And then there were studies with von Economo encephalitis in 1920s. So there were studies done, but they were always studying, quote, interesting patients. Well, my approach was different. I said, every patient is interesting. So I'm going to study as many patients as I can. Whoever agrees to have neuropathology studies, I will study their brains. So we did autopsies on whoever family agreed to have the autopsy done. Very soon we realized that we really don't need to study pathologically the whole brain. We could study half brain and froze the other half at -80 degrees. Once we had that, then we said, well, let's study the brain biochemistry, which we did. And then we studied genetics, which we did, and TIPU is part of that. And then mixture of all those from clinical on to the genetics studies, that keeps going. Now, this is a summary of what our labs look like. These are clinical records here. Picture one is clinical records. We keep all the original clinical records. This is still old-fashioned stuff. Every patient that has come to autopsy, we have the original records. Then you see in picture two, there's a freezers. Now, these are -80 degree freezers. These freezers, we have now 10 of those. And these, you see boxes there, you see the SK numbers there. Each box contains half frozen brain. They are identified by SK numbers, and each brain is kept separately, so they do not touch the other one. So there is no genetic mixing up. On picture 4, you see now we keep the formalin fixed brains that the pathology department gives us back, what remains, and we keep that now. And picture 5 shows we have the slides and we have the slides and the paraffin block. So we have the whole brain in one form or the other available to us. And these are videos. We have now more than 4,000 videos on our own patients, some of them multiple ones. And we use those, and the videos are done on every patient that agrees. It's not the interesting patients, but every patient that agrees. So we have a lot of videos, and whenever we have the videos, we may use them with the clinical information, videos, and pathology for our presentations. The program, with time, it became known that our resource was quite unique. My first outside collaborator was in mid-1970s, Professor O. Harnikevich. Now, those of you who don't know who Harnikevich is, he was the first person who described that you can analyze the brain, human brain, for neurotransmitters. So he did that. And the second phase he very quickly did was he analyzed the brains of Parkinson's disease patients and controls. And he found out that's the first study of human brains which shows that there's a lack of dopamine in Parkinson's disease patients. Then the third thing he did was, I mentioned earlier, that he, along with Berkmeyer, gave intravenous levodopa 1 year later in 1961. And they said that it works very well. Now that was further expanded by Katsias, who gave large dose of oral DL-dopa. Now Harnikevich was the finalist for the Nobel Prize for 2000. He didn't get it. They gave it to a Swedish person, and we objected to that. A number of us objected to that and said, well, you have given credit of the work done by Harnikevich to the Swedish person, but really it didn't change the Nobel Prize. But the fact is, that's the level that this person was. And in 1996, we officially appointed him as distinguished professor with no salary. That was the right price for me, no salary. And he would come here and work with us a couple of times a year and then go back to Vienna. He moved from Toronto to Vienna, where he was originally from. We have since then attracted many leading experts, collaborators, including TIPU. There are currently approximately 40 or so institutions and individuals that have collaborated with us. We are able to pick the questions which others find difficult or impossible to answer because of our resource. We can answer major difficult questions, as I said. I will share some examples for you. Now, this is Parkinsonism in essential tremor cases. That's a debate. Clinically, Parkinsonism has tremor and essential tremor has tremor. Some essential tremor patients also develop resting tremor, and some Parkinson patients also has postural action tremor. So there's an overlap between the two, but the pathology is quite different. There's several studies by other people which show that essential tremor patients are predisposed to Parkinson's disease, and other study which show essential tremor patients are predisposed to progressive supranuclear palsy. Well, in this we did the study and said, and reported just 2 years ago, and said, no, there's no particular variety of Parkinsonism which is more likely to occur in essential tremor. All varieties of Parkinsonism occur in essential tremor. And there's another debate going on, and if you go to the meetings, they're heated debates, theoretical oftentimes. It was that the disease, Parkinson's disease, was a transmissible disease, a prion disease. Well, how do you find that answer? Well, we studied these 5 couples. They were both wife and husband. They've been married for a long time, some more than 40 years. And we had autopsy on each one of them. We found out that it was not really a disease that was transmitted from one to the other, because the husband had one kind of disease and the wife had the other kind of pathology. So we said, no, it's not transmissible. So we answered that question. Then there was another debate that if you have older Parkinson patients, your pathological base is different than the younger Parkinson patients. Well, we studied that octogenarian Parkinsonism from our own data and found there was no difference. They all have the same kind of disease. They are older, so they have some other comorbidity, but they all had the similar disease, idiopathic Parkinson's being the most common one. Well, you see in some patients on levodopa, I mentioned before, they were having dyskinesia, and some people have wearing off, and some people have both. So in this study, we studied the brain dopamine metabolism in levodopa-induced dyskinesia and wearing off. You can see the name here, Hornikevich here. So this was when we found out that there was a difference in how the brain metabolized dopamine. Wearing off patients broke down dopamine more rapidly than the dyskinesia brain. So that makes sense. You get hungry sooner, so you want to refill again. But dyskinesia patients had a lot longer dopamine staying in the system after it was formed. So that's the first study of that kind that I know of. This one is a genetic study. Again, we have a large number of genetic studies as well. And this is a large family where we have studied. And the names here indicate to you that there are multiple institutions that are involved in this study. So this family we have studied, we are still following these family, DNA JC13. And they have 2 kinds of pathology. Some of them have Lewy body pathology, some have tangle pathology, and there are some patients in that family who don't have this genetic mutation, but they have PSP, progressive supranuclear palsy. So this is simply to show you that we have had collaborations with a large number of people at different times. For the younger scientists, some advice. Evaluate your circumstances carefully, what can be done and what you cannot do. Be realistic in what you can do. Focus on what you like to do, what the local strength allows you to do. Whatever you do it well. Don't do a sloppy job. Do it well. Be honest in what you do or say. You will make mistakes as everyone else does, but never deliberately mislead people. It will establish your reputation, who you are. See if you can convince others to join you, as we have done over the years. When someone joins you, give that person full credit. Do not take credit away from that person. It will help you. Keep an open mind. You are going to be doing certain projects, but you may find some other alternatives to do some other good work. Do not become a one-trick pony. Keep your options open. What else you can do? And finally, do not hesitate to question others, as I gave you the example of levodopa doses. But do it in a respectful fashion. Do not hesitate to question others, but do it in a respectful fashion and provide good evidence before you do it publicly. That's what I did. I was telling you, and I started questioning in 1968 and I published in 1984. Nobody questioned that after that. So that's my advice to the younger people. Thank you very much, and I will answer any questions that you have.
Thank you very much, Dr. Rajput. This was great and very inspirational too. So I would open the floor to our audience. If they would like to unmute yourself or just want to give a comment or ask a question, they can go ahead and do so.
Okay, I'm here. I made it so clear, but probably they don't have any questions.
Ali, what are you doing? What are you doing now?
Tipu, I shouldn't say semi-retired, but I continue seeing patients. With COVID thing, the practice has changed. I'm sure yours has changed too. So a lot of telephone consults, but I still have to go and do the Botox in the office, in the clinic. So I continue doing what I do, what I did before, only at a slower pace, less productive than before. And, aches and pains of old age, you know how it is, but I'm still keeping active. Thank you. How about you, Tipu?
I'm fine, but you are a great and amazing example for all of us of your academic acumen and your clinical acumen and your ability to laugh at difficulties in your life that you and then continue to go on. I think people don't know, you didn't talk about the wonderful things that you did in the face of adversity and opposition to your research, in which you were vindicated at the end.
Well, thank you, Tipu. I'm sure you have done great things yourself in your circumstances, and I'm very proud of you.
Naila wants to say something. Go ahead.
Dr. Rajput?
Yes, Nala. Assalamu alaikum.
Wa alaikum assalam. I just want to say I've been a neuro nurse for a long, long time, and it was working with you and that Saskatoon or Saskatchewan Parkinson's family that you finally made me understand, and it was an uphill battle, what makes Parkinson's disease. So I will be forever grateful for that, because I'd already been a nurse about 35 years and I still didn't have it straight. So thank you very much for many things. Also for making us understand, all of us, neurologists especially, I think, that everything starts with the patient.
That's right. Well, if you're a clinician, that's where you start, and you have to focus on what your strength is, If you go on, you can build around it, but you have to focus on what you're able to do well. And if you're able to do well, then at least you have some anchor to hitch on to. And then you can build on that thing. Tell me, how's your daughter doing?
That one, Thibaut.
No, you can tell her.
Well, she's good. She's working for a new startup that is based half in Pakistan and half in Malaysia. She's here though in Chicago. It's a group that wants to open the market of Pakistani artists to international buying. So that's what she's doing. She's herself an artist, as I think you know. And she many days mentions the bird catching of Dr.
Oh,
Rajput.
yes. Well, give her my salams. Wish her well. Now, art is not my forte. I failed art exam.
But she remembers how you could make birds disappear and bring them up.
Anyway, good to talk to you, Nara.
Ali, this is Ashfaq. Immensely enjoyed your presentation. Brought back the days when my office used to be 2 offices down from yours. Wonderful job. Amazing inspiration for all of us. My question to you is, you have this huge database and these massive number of patients whose autopsies and brains you have. What are the plans for them? What would you do in the years to come with the whole enterprise?
Well, in the years to come, I will retire. That's one. Alex is in charge of the program now. He's my boss now. Alex, those of you who don't know, is my son. And he's now in charge of that thing. Now, one of the things that I told you about, Hanikevich was coming here. He was professor. He's passed away last year. When you have these brains and you're going to study any area of the brain, and these are specified areas, you just can't study the whole brain, you know. So you need to precisely identify that area before you can subject to study. Genetics can be done in multiple areas, but they are more precise area, like you have a substantia nigra, a striatum, cerebellum, or subthalamic nucleus, or whatever. Now, those areas have to be studied specifically, and they have to be identified specifically in the frozen brain. That method was devised by Hanikevich in 1959, 1960. So when Hanikevich came here, after he was appointed and he started coming here regularly, I told him that he should train Alex to do it. So now Alex is the only neurologist that I know of who can do that. He will dissect those brains, precise areas that you need, and then you analyze that. So that particular link, if we had not developed that, we would now be without any alternative. But with Alex there now, we can pick and choose the questions. Actually, I pick and choose questions. Probably once a month, I will choose a question that I am going to study. And then we will go and see who is the best person who can join us in that, or can we do it alone? And carry on with that. So Alex he has been working with me since he was 15 years old. So I think it's in his blood now, so he can handle it quite well now. Thank you. Did I answer your question?
Inshallah, I wish you all the best.
Thank you.
This was so nice to see you, and the outstanding presentation.
Thank you. Thank you, Ashfaq. Well, you've done a tremendous job. We kind of miss you, but hey, it's better that we have 2 places of excellence than 1 place of excellence.
Dr. Rajput,
I'm in a car, so I keep on missing out some of the. I'll probably sign off right now. Adil, over to you. Huh?
Yeah, thank you so much. Dr. Rajput, I was thinking of one question. Do you know if there's any difference either in the gross pathology between the brains who have undergone deep brain stimulation versus those brains who have not gone deep brain stimulation?
No, we do not have any. We have some patients that have deep brain stimulation. We not have enough of them there that I can make make a statement on that thing. But we do have some. We haven't looked at how many are there. They're probably less than a dozen, that we have of deep brain stimulation. But with time, we will be collecting those, And we have done essential tremor, dystonia, other things.
And I don't know much about genetics, but nobody knows how DBS works. Everybody says that, hey, it lowers down this pathological beta oscillation in the brain within the STN, within the GPI. That's how it traces the tremor or the bradykinesia. So it could be epigenetic phenomena too, right? So perhaps maybe if we could do those studies in those brains who have undergone DBS versus those brains who have not. I don't know if we could do it.
Well, as I said, the human body is the same. Why do some places have outstanding papers or the journals think they're outstanding, others don't? Because of the depth that they go into it. If you have only clinical one, you have a certain level. If you have clinical pathologies, a different level. If you have clinical pathology, biochemistry, it's a different level. If you have clinical pathology, biochemistry, and genetic, you have a different level. So whichever institution is able to do greater in depth, their work is accepted more by the journals. So it's possible, it can be done, but as I said, we do not autopsy patients that we have not seen. We want the data, our own data. If my next door neighbor has seen the patient, but I have not seen, Alex has not seen, we will not on the brain.
But if you ever get interested in doing anything related to deep brain stimulation or electrophysiology, combining that with what you have, or if you see the patient in the future who have undergone DBS, do count me in for any collaboration. I would be happy to learn from you.
Oh, well, thank you. I am not very good at electrophysiology because we don't have the program. We didn't have, in fact, the geography is such that for many years, or maybe a good 15 years ago, we didn't have a neurosurgeon in Saskatoon who did the deep brain stimulation. There was a neurosurgeon in Regina who did, and he asked me to collaborate with him. I said, yes, I will collaborate with you on one condition, that you show me all the patients that you've done. Not the ones that you succeeded, but all the patients that you've done. I'm old enough to know how you can selectively say, I'm great, showing just those patients, but I want to see all the patients that you have done. So he didn't want to do that. And I said, well, then I can't collaborate with you. So this program of deep brain stimulation came later on in our place. And we were already, the only two of us movement disorder persons. Our hands were full completely. We didn't have any time to do anything more. So we haven't been able to delve into that.
All righty. Does anyone has any more questions? If not, then I think we are reaching 1 p.m. Eastern time.
Well, whatever your time, I'm free. You're welcome.
Yeah. I think we can close the session. Thank you so much once again for taking the time out and giving this great presentation.
Thank you.
Thank you, Ali.
And thank you, Linda.
Ali, I'll call you later.
Thank you so much.
Thank you.
Ali, I'll call you sometimes when you're free.
I will. Well, that'll be nice, people.
Okay.
All the best to all of you. I wish you much success, younger generation. I'm the older generation, so I can only share with you what I have. You have many more options in life, and I wish you all the best.
Thank you so much. Walaikum assalam.
Okay.